And Jeff, let me ask you this, and Patti, chime in here as well, because that's a point that you've said routinely, whether it be on the listserv, whether it be in presentations about this follow-up. Why do you think that's such a vital thing for people to understand to work effectively within primary care? Because it's definitely, when we think about, when we're training interns, and it's not the way people are trained in mental health care. People trained in mental health care are kind of trained to do it through completion of symptom reduction and to the absence of symptoms. Why do you, if that ever happens, why do you all feel that's a vital thing for people working in primary care to just be aware of? This idea is, if people are improving,
they got the right trajectory, it's okay to,
great word,
kind of come back and be brought back into the care on an as needed basis.
Yeah.
I think it's just it contrasts with our more traditional way of working as mental health kind of professionals, where we're trying to deliver more packages of care, thinking that there's a certain number of skills that we want to teach and that we need to get people through the curriculum and the series of interventions so that they're fully treated. And that it certainly appealed to me that when we look at the way people behave in relation to use of people with expertise like us, it doesn't fit their perspective. People are more likely to kind of come in when they're feeling distressed and to stop when they're feeling better. So this way of working, consulting with them when distress is high, I think we ultimately get a lot more care delivered, a lot more skills kind of available to the person because they're available at the time they need them. So
Patti, go ahead.
Yeah.
One other, can I just add one thing real quick? Yeah, I think the other reason, to operate this way is that it helps keep your access for patients, right? I mean, if you're following everybody until, remission, or, planning to do that, you're quickly gonna get clogged up with patients. So this consultant follow-up structure also helps you just maintain your accessibility to patients and the team.
Yeah, and I was just going to add on to what Patti was saying about the practical nature of the services. Somebody is dealing with something in particular, their stress threshold is beyond max. They come in, they get what they need. It's not necessarily coming at this and being like, okay, well, you have this problem, and for this problem, we are now going to prescribe you 12 sessions of this to eradicate that. That might not really hit home for the average person. For the average person's like, hey, I'm going through this situation. You're able to have that consultation, that visit with them. They get what they need, they implement it, and they're like, wow, cool. Like, I got what I needed. So a lot of our patient satisfaction data, and when they go through the qualitative statements of, they say something like, what was your favorite part of your visit? The amount of comments that relate back to, it was effective, it was practical, I got what I needed, it was quick. There's actually a lot of the statements that are like, it was quick and I got what I needed. So it really kind of highlights exactly what Patti is saying, versus it necessarily having to be this drawn out process.
I was listening to interaction between someone I was training in New Zealand to work as a behavioral health consultant and a patient she'd been seeing in a different model of care. And so she was explaining that she was now going to work in a different role. And one of the things she said is, so our visits will be shorter, and I will be able to see you on the day that you want to be seen because I have same day appointments available every day. And so rather than scheduling every 2 weeks, you just call when you want to come back. And the patient said, oh, that sounds much better for me. Because she was like, it's awfully hard to try to get in here sometimes. And, I'd rather just come if I need to.
Pat,